Hello, hello. Welcome back, everyone. And I hope every one of you is doing good. I'm sorry for the delay, and I'm sorry for yesterday as well. Yesterday, I get some sudden work that was urgent work. So I have to cancel the class at the last moment, and I'm sorry for that. Okay. All right. So we're going to start from where we left. Anybody have any question? Any confusions before I start? Everything good? All good? Okay, let's start our class. So we completed till progesterone. That was our last topic. And today we're going to discuss the oogenesis, female reproductive cycle, pregnancy, Apgar scores. So oogenesis. Oogenesis is a process by which your ovum is getting matured for the fertilization, for the process of fertilization. That is called the oogenesis, the process by which your oocyst is getting matured or getting ready for the fertilization is called your oogenesis. So can anybody tell me what is the location of oogenesis? Where does the oogenesis takes place? Yep. Oogenesis takes place obviously in the ovary because your ovum is present in the ovary. So oogenesis is actually taking place where it's taking place in the ovary. Now within the ovary, we have the two types of cells being there. We have the two types of cells being there. We have the theca cells and the granulosa cells. Can anybody tell me in what cells of the ovary the oogenesis takes place? In the theca cells or in the granulosa cells? Yep. These are little bit basics, and I want to make a foundation before I start the menstrual cycle. So oogenesis takes place in the granulosa.
Granulosa.
Very good. Why your response are delayed? Be quick.
Sorry.
No, no, don't be sorry. I'm just kidding, okay? All right, so granular,
Okay, thank you.
no problem, anytime. Okay, so granulosa cells is a site where oogenesis takes place. And remember, oogenesis begins with what? So oogonium. So we do have the oogonium, which is actually immature ovum. Oogonium, oogonium will be converted into what? Is going to be converted into your primary oocyst. Primary oocyst. Primary oocyst. So it's going to be converted into the primary oocyst. Now this primary oocyst is actually there. So when does your primary oocyst will start the meiosis one? So primary oocyst will undergo the meiosis one. It will undergo the meiosis one. It will undergo the meiosis one during the fetal life. During the fetal life, it starts the meiosis one. Okay, during fetal life. So when will it actually complete the meiosis one? Primary oocysts undergo meiosis 1. It undergo meiosis 1 during the fetal life. During the embryonic life, it's undergo the meiosis 1. It's different from the spermatogenesis. Spermatogenesis, primary spermatocyte. Do you guys remember? I discussed with you. Primary spermatocyte start the meiosis 1 at the time of puberty, but primary oocyst will start the meiosis 1 at the time during the fetal life. And when it will complete the meiosis 1? Because primary oocysts get arrested in the meiosis 1. What phase of the meiosis 1 your primary oocysts get arrested? Anyone?
Metaphase.
No, it's prophase. Prophase. Pro means one, so it's for the prophase. Okay, so it get arrested in the prophase one of meiosis one. Is it prophase one? Get it? So that's going to be the prophase one. All right. Now, at what time it will complete the meiosis one? It will be converted into your secondary oocyst when it complete the meiosis one. So when will it complete the meiosis one? Anyone? It is going to complete the meiosis 1 just before ovulation. That's very important to know. It is arrested. Look at this. During fetal life, it starts the meiosis 1 and it get arrested in the prophase 1. So what will happen? You see, it's going to be converted to secondary oocyte at the time of the ovulation, just 1 day before the ovulation. So just prior to ovulation, it will be converted into secondary oocyst. Okay. Now the secondary oocyst is going to do what? Secondary oocyst will undergo the meiosis too. Okay, so secondary oocyst is going to undergo your meiosis too. Meiosis too. Meiosis too. But remember, secondary oocyst will only complete your meiosis two until your fertilization. Once your fertilization happens, then only it will then it will only complete the meiosis two. Okay, otherwise it get arrested in the meiosis two. So it will only complete the meiosis two until fertilization. So before fertilization it will not complete the meiosis two. So it means secondary oocyst also get arrested in the meiosis two. Can anybody tell me the what phase of meiosis two? Yep. What phase of meiosis two it will get arrested? Yeah.
Metaphase.
Okay, excellent. That's very, very important to know. It get arrested in the metaphase two. And when it get arrested in the metaphase two, it will remain in the metaphase two until your fertilization. Once your fertilization happen, your secondary oocyst, that's actually your secondary oocyst, is going to be converted into what? It's going to be converted into the ovum, mature egg, ovum. Okay, so this is called your oogenesis. Very simple. Just you have to remember these phases. Meiosis one is arrested for the primary oocyst. Primary oocyst would get arrested in the meiosis one in the prophase. In the prophase. Now another is called your secondary oocysts, which get arrested in the meiosis 2. It makes sense. Secondary means meiosis 2, primary means meiosis 1. Pro means 1. So this is a way to remember. Metaphase is the second phase of the meiosis 2. So secondary oocysts get arrested in the metaphase. Get it? So this is how oogenesis takes place. Now I will discuss the menstrual cycle for the female. Okay? So let's discuss the menstrual cycle. So menstrual cycle. So, what is the definition of menstrual cycle or description of menstrual cycle is a periodic cycle which prepared the female for the fertilization and the pregnancy. So, if you just focus on the definition, then it will be very easy for you to understand the changes which are happening during the cycle. Okay, so what is actually it's actually periodic cycle. So, I'm writing a definition periodic cycle because it will run after every 28 days. Periodic cycle periodic cycle prepares which prepares periodic cycle which prepared the female for ovulation or fertilization, whatever you called, for fertilization. Okay, for fertilization and pregnancy pregnancy. Got it? All right. So this is called your menstrual cycle. So there are menstrual cycle is divided into the two cycles further. One is called ovarian cycle, another is called your uterine cycle. So first we will discuss the ovarian cycle. What are the phases of ovarian cycle and what are the phases of uterine cycle? So let's quickly discuss ovarian cycle. Ovarian cycle. So in the ovarian cycle, we have the two phases. One phase is called the follicular phase, and another is called the luteal phase. So let's discuss the follicular phase. What changes will happen during the follicular phase? So follicular phase. So your follicular phase will start from where? It's going to start from the day one of the menses till the ovulation. The the period or the cycle or the phase which start from the day one of menses, day one of the menses till your ovulation, till your ovulation, that is called your follicular phase. Now, this follicular phase is stimulated by what hormone? Can anybody tell me the name of the hormone? So, what is happening in the follicular phase? Your ovarian,
FSH.
yes, very good. So, your ovarian follicle is getting matured. The follicle is composed of the theca cells and the granular cells. So, here your immature follicle is converted to mature follicle. I mean to say, the size of the follicles will increase and until it get ruptured. So follicular phase is actually what is a phase that is start from day one of the menses till the ovulation, and this is actually stimulated by your, I would say, your FSH. Now the time period, do you know normal female cycle is 28 days cycle? So if it is a 28 days cycle, your follicular phase is going to be of 14 days. This is the phase which is actually variable. In the females, this phase is very variable. Okay, so it depends upon the number of the days. If female is having the cycle of 40 days, if female is having the cycle of 40 days, so what will be the how many days the follicular phase is there? Can anybody tell me what's the duration of follicular phase? If female is having the cycle of 40 days, 40 days. So what will be the length of the follicular phase? Oh, no, not 20, not 20. So remember
40 minus 14.
26. Excellent. This is actually right. Aisha is right. It's 26. Why 26? Because remember your post-ovulatory phase, which is called luteal phase. That will be always of the 14 days. That will always be of the 14 days. Whatever happened, that will be always of the 14 days. So 40 minus 14, it will be equals to 26 days. So this follicular phase is very variable. Why it is variable? Because it depends upon the your blood level of the FSH. FSH level variable, so you get the variable cycle. Follicular phase is actually variable one. Okay, so after follicular phase, what will happen? You get the ovulation. You get the ovulation. Ovulation. So ovulation is there. So ovulation means the what is ovulation? Follicular rupture that leads to the release of secondary oocysts. So that is actually called. What's the definition of ovulation? You get rupture of follicle, rupture of follicle, rupture of follicle that leads to what? That leads to the release of secondary oocyst. Secondary oocyst. Okay, that release so release. So okay, oh, that's called ovulation. Now, you know what hormone? Can anybody tell me what hormone is going to lead to ovulation? I mean to say, level of what hormone, if it peaks, you will get the ovulation. Ovulation,
LH.
LH. When you get LH peak, very good. When female, normal females will have the LH peak at the day 14, 14 day. Okay, 14th day of the cycle have what? So that's actually going to be LH. LH surge is going to cause it. Okay. Now LH release is going to be there, and this LH surge is mediated by estrogen. Remember, throughout the cycle, estrogen have the negative feedback effect on the LH release. But at the time of ovulation, increase estrogen will lead to what? Increase LH. So this is the only time mid-cycle, mid-ovulation cycle. This is the only time where your high estrogen is going to lead to, okay, so high LH will be seen. Get it? So this is actually called ovulation. Now, some females get, pain at the time of ovulation, at the mid-cycle of the. So what is the name of that term we use? Can anybody define that term for me? If any female
Mitchell
Merge.
Mittel's pen.
Mittelsmurg's pain. Very good. Mittelsmurg pain is actually what? So Mittelsmurg pain is actually your pain with ovulation. You get pain with the ovulation. That's called Mittelsmurg pain. And what's the reason of this pain? The reason of this pain because once your follicles get rupture, it might lead to the bleeding. So you might get some bleeding within the ovary. So that bleeding will do what? So you get some bleeding. Some bleedings will be there, and that bleeding is going to lead to what? Peritoneal irritation. you get peritoneal irritation. Peritoneal irritation. Okay. So that is called the Mittels-Meigs pen. Now this will be your unilateral or bilateral? Anyone?
Unilateral.
Unilateral, very good.
Hmm.
Unilateral, and it might looks like your acute appendicitis because it can be right lower quadrant pain or right left lower quadrant pain, depends. Okay, so that could be unilateral or bilateral. Get it? Okay, sorry, unilateral, never be bilateral. Get it? So that will be your ovulation. Now after ovulation, what is going to happen? Your follicles, once follicles get ruptured, it will be converted into corpus luteum. So your luteal phase will start. Remember, this luteal phase will always be of the constant duration. It's going to be of the 18 days, always 18 days, not greater than 18 days. Okay? It's going to be always 18 days, not greater than the 18 days. So luteus phase will start when your follicles, which is ruptured, it will be converted into corpus luteum. Corpus luteum. So you get corpus luteum formation. Okay? Corpus luteum formation will be seen. And this corpus luteum is going to do what? It's going to this corpus luteum is going to produce the progesterone only. So the role of corpus luteum is to produce the progesterone. And why it produces the progesterone? Because it wants to support the pregnancy. It wants to support it wants to support the fertilization. It wants to support the fertil. Oh, sorry. Yeah, very good. Thank you, Sony, for making me correct. Thank you. Okay. I think I said 14 days, but I write 18. Is it? Am I right?
Yeah, you said previously it is fixed 14 days.
Yeah, I said 14 days. Sorry. Thank you for correcting me. Thank you. Thank you so much.
No problem.
Okay, thank you. Okay, so it affects 14 days. So that's called the luteal phase. That's going to produce the progesterone. So progesterone is going to be produced during, and that progesterone is going to support the pregnancy. And I already discussed the, functions of the progesterone. Now let's discuss the uterine cycle. So uterine cycle is a say is a second component of your uterine cycle is a second component of your menstrual cycle. So uterine cycle is divided into two phases. I would say three phases, not a two phases. So uterine cycle always start first with the menses. Menses. Menses means female is actually passing the blood. So she passed the blood through the birth canal. She passed the blood through the birth canal. That will be the start of the uterine cycle. So uterine cycle is start with the passage of the blood through the birth canal. And that passage of the blood will be due to what? Passage of blood? Yep.
Shedding of the endometrial lining.
Yes. Why endometrium is actually shedding? Passage of blood through birth canal. The reason is there. Reason is that
Withdrawal of
yes,
hormones.
yes.
No progesterone support.
Once your progesterone level go down, once your luteal phase in the ovary is over or is actually finished, it leads to reduced progesterone. So no progesterone, no support of the endometrial lining. So your endometrial lining will actually shed down. Okay. So passage of blood through the birth canal. Okay. That will be called your, I would say, uterine cycle. Now that's all uterine cycle. Now coming to your menses. So after menses, what will happen? Your your menses normal duration could be 1 to 5 days. If female is having the menses for 1 to 5 days, it's actually normal. Now after 1 to 5 days of the menses, you get the start of proliferative phase. So proliferative phase means the endometrium will actually regenerate. The whatever is being lost, it will be replaced. It will be replaced with the proliferative phase. So your proliferative phase is going to start. Okay. And this proliferative phase means you get endometrial replication. So who's going to stimulate the proliferative phase of the uterine cycle? Yep.
Estrogen.
Estrogen.
Excellent. Estrogen coming from the follicles of the ovary will stimulate the replication of your endometrium. So whatever is being lost will be replaced during the proliferative phase. So it's also called endometrial development phase. Endometrial development. Endometrial development. Please keep yourself mute. Who's this? Please, please. This is my humble request to you. Okay, I'm going to do it. Don't worry. Okay, so proliferative phase. Now, this proliferative phase is there, which is actually running with the follicular phase of your ovarian cycle. So once your proliferative phase is over, means your estrogen level will go down. And why will the estrogen level go down? Because your follicles get ruptured. So after ovulation, proliferative phase will be finished. I would say proliferative phase will over. And once your proliferative phase ends, your secretory phase will start. And the secretory phase is actually what? Secretory phase. So secretory phase starts. Okay. So this secretory phase is going to be what? It's actually it's being mediated by progesterone. Progesterone will increase the glandular secretion of endometrium. Progesterone. Get it? So progesterone is going to, stimulate the secretory phase. So what will the progesterone do? It is going to prepare the endometrium for the implantation. So it will lead to the, coiling of the glands. So coiling of the glands and changes in the blood vessels will be seen. Can anybody tell me what will be the shape of the blood vessels here? It will be linear or spiral?
Spiral.
Excellent. A spiral. Very good.
Spiral.
It's going to be spiral, which is going to support the endometrium. Okay, so that's called the secretory phase. Is very, very, very easy, stimulated by progesterone. Now, once your progesterone ends, once your progesterone levels go down, your secretory phase will stop and your cycle will repeat with the menses. So, endometrium will shut down. So, this cycle is going to be repeated. Now, your progesterone will go down only when there's no fertilization. If there's no fertilization, the corpus luteum will degenerate into corpus albicans. Okay, and but if there's a fertilization being there, if there's fertilization there and pregnancy happens, then your corpus luteum will remain. It will remain and keep producing the progesterone. So female will not bleed. She will actually support the pregnancy. Corpus luteum is going to remain. So can anybody tell me who's going to maintain the corpus luteum and will request the corpus luteum to produce the progesterone?
Beta HCG.
Beta HCG. And remember, beta HCG will only be released when there's an implantation, when placenta is formed. Okay, when the placenta is formed, which I'm going to discuss in the pregnancy. So that's all about your cycles being there. Now we will discuss the pregnancy here. Then we will discuss the abnormal uterine bleeding. So let's discuss the pregnancy. Okay, anybody have any questions regarding cycle? All good? So pregnancy is defined as what? Pregnancy is defined as you get the fertilization of the ovum is called pregnancy. Or when the embryo fuses your ovum is called the pregnancy. Okay. So what is the most common site of the pregnancy? Where does the pregnancy normally happens?
Ampulla fallopian tube.
Ampulla of fallopian tube. Very good. Good job. Most precise answer. Ampulla of fallopian tube. So once your fertilization happens in the ampulla of fallopian tube, the embryo or zygote should move to the uterine cavity. Uterine cavity. It should move to uterine cavity. Is it? It should move to the uterine cavity. And if once it moves into a uterine, so who's going to mediate this movement? Anyone? Who's going to, what structure, what protein is going to mediate this movement to the uterine cavity? Yep.
Dynein and kymation.
You are very close, and your answer is correct. That's called cilia, dynein arm of the cilia. So ciliary movement is going to facilitate to the uterine. So it is going to take 6 days for the zygote to reach to the uterine cavity after fertilization. So your implantation will happen after 6 days of the fertilization. Implantation. Happen after 6 days of fertilization. Okay. Implantation is going to happen after 6 days of the fertilization. Okay. After 6 days of fertilization, your implantation is going to happen. Get it? So, all right. So once your implantation happens, your placenta formation will happen. So placenta is composed of syncytotrophoblast and the cytotrophoblast. Syncytotrophoblast is there, which is the outer layer, and cytotrophoblast is your inner layer. So syncytotrophoblast will start producing your beta HCG, which indicates the pregnancy. We use beta HCG test to detect the pregnancy. So beta HCG will start to rise in the blood and the urine. So after how many days of fertilization, beta HCG is going to, beta HCG will be detected in the blood. Yep.
8 days.
Very good. 8 days, 7 day, how much? After how many days of fertilization, beta HCG will be seen in the blood? That will be after 7 days. Very good. Very good, Aisha. Okay, 7 days. So after 7 days, it will be visible in the blood. And after how many days, it's going to be visible in the urine, which is a home pregnancy test.
40.
14 days, so
14.
2 weeks. After 2 weeks, it's going to be there. Now, in the pregnancy, so if you want to diagnose the pregnancy, one is the beta HCG, others are the placental hormones. Now we have to determine the age of the pregnancy or age of the fertilized ovum. So we use two criteria. One is called your embryonic development, and the other is called your gestational age. So embryonic age. How do we calculate the embryonic age? Anyone? Embryonic age. Embryonic age.
From the days of fertilization.
From the day
Since
of
the
very
fertilization.
good time since fertilization. Time since fertilization, it's going to be the embryonic age. So time since fertilization is going to be the embryonic age. Okay. Give me a minute. I will be here. I'm getting some call. Yes. Sorry. Hello. Sorry. I'm sorry for any inconvenience. Sorry for any inconvenience. I get one call. Okay, sorry. So we are discussing embryonic age. So we are going to calculate the embryonic age since fertilization. Now there's one other age which is called gestational age. So how will you calculate the gestational age? Gestational,
First day of last menstrual period.
excellent. From the last menstrual period, first day of the last menstrual period, that's called the gestational age. And now other are very simple, gravida, para, which you guys know. Gravida is actually the term of the number of pregnancies. Para means the number of pregnancies that result in the, live birth. So that's these are terms. Now we are going to discuss very important one, physiologic changes in the pregnancy. So what physiologic changes we will see? Because pregnancy is going to change every system of the body. Physiologic changes in the pregnancy. So it's going to change every system of the body. And what is the purpose of these physiologic changes? This is very important to know. If you understand this purpose, it will be easy for you to understand the every changes. So purpose of this physiologic changes are what? So mother is actually adapting to actually support the pregnancy or to actually nourish the baby. So it's going to maternal changes are there that they are going to what? They're going to support the pregnancy. So you get what? So mother is going to adopt to actually nourish the baby properly or to supply the nutrition to the babies properly. And second purpose is mother is actually preparing herself for the labor and the delivery. So these are the two purposes. So mother is going to prepare herself for and delivery labor and delivery. And the other purpose is what? She's going to actually support or nourish her baby. These are the changes. So we will discuss every system's changes, nourish the baby. So these are the two purposes. Now let's discuss your, I would say, the CVS changes, cardiovascular changes. So what cardiovascular changes we are going to see during pregnancy? So during pregnancy, the blood volume is going to be increased. The plasma volume increases. And why the blood volume increases? There are two reasons. One reason, the more blood should go to the baby for the proper growth of the baby. And second reason, at the time of delivery, mother is going to lose the blood. So she is going to, she will already prepare herself for the loss of the blood. So this is the reason your blood volume will increase during pregnancy. So blood volume will increase. So if you increase the blood volume, it will increase the preload to the heart. And if you increase the preload, what will happen? What will happen to the stroke volume?
Increase stroke volume.
Increase.
So your cardiac output goes up, and similarly, your placental perfusion is going to be increased. So this is the one way to increase the perfusion of the babies. Mother will do everything to support her baby. So increased blood volume will lead to increased placental perfusion will be increased, or baby's perfusion will be increased. This is the one way she will increase the blood flow to the baby. Now, other way she will increase the blood flow to the baby, she's going to have the decreased systemic vascular resistance. So afterload will be decreased. So when your afterload decreases, more blood will go to the baby. So these are the two ways through which the mother will send more blood to the baby. Now, can anybody tell me what's the third way she's going to increase the blood flow to her baby? Uh-huh. Yep.
Venous pressure.
You close, you close. Remember, what's the equation of cardiac output? If you increase, you know, if you want to increase the
Heart rate.
excellent, very good. So with the later pregnancy, as your pregnancy progresses, it will lead to increased size of the uterine cavity, and uterus size will increase, which might produce the resistance. So mother is going to increase the heart rate to increase the cardiac output for the baby, is it? Or increase the perfusion of the baby. So this is actually happening during the time of late pregnancy. But early pregnancy, blood volume is going to be increased and system vascular resistance is going to be decreased. Now, pregnancy causes the edema. Have you seen the pregnant lady is having the lower extremity edema, peripheral bilateral lower extremity edema? What's the reason of edema here? Can anybody tell me?
Due to increased peripheral venous pressure, right?
Yeah, you
Because of the progesterone, this
very
vasodilation and progesterone.
close, very good. So one reason is
And gravid uterus. And
gravid.
gravid uterus also in the late
Excellent,
pregnancy.
excellent. This is reason. Gravid uterus is going to do what? It will not allow the venous return to go, to the heart. So all the blood is going to remain in the lower extremities. This is the one reason. And second reason is that what about early pregnancy? Peripheral edema is very common during the late pregnancy. But what about early pregnancy? In early pregnancy, the uterine size is not that much. But why the female is getting the, I would say, the edema?
Because of preeclampsia, preeclampsia, raised blood
Preeclampsia, where are
pressure.
you going? Preeclampsia is something different.
It's
Normal, no. Oncotic pressure. Very good, Archana. Very good. Excellent. So what will
it's
happen when you increase the volume of blood? When you increase the volume of blood, what will happen when you increase the volume of blood? Increase.
my theory, or it's like at the beginning of the pregnancy, because the blood filled the placenta, it will drive the blood away from the maternal circulation, and this lead increase the renin in the kidney of the mother, and it will lead to salt and like the sodium and water
I'm
retention.
coming to that.
And that's why.
Renal changes. I'm coming to that. Okay. If you mix it, you'll get confused. So go in the systemic way. It will help you, to be honest with you. Okay. All right. So you're right. You're right. Your reason is also right. Second. So that we will discuss in the
I mean, that's the answer for the edema in at the early pregnancy.
early pregnancy. That's not an answer, to be honest, genuine answer. So genuine answer is actually what? With the early pregnancy, your blood volume increases. So if you increase the blood volume, you will actually dilute the albumin. Is it? So you're going to dilute the albumin. Dilute the albumin. So when you dilute the albumin, what will happen? When you dilute the albumin. So dilute the albumin, your oncotic pressure will decrease. So decrease oncotic pressure will lead to the edema. Did you understand that? Does it make sense to you?
Yes.
So that's what happened with the early pregnancy, is it? All right, so that will be your cardiovascular changes. Now coming to the GI changes. What GI changes you will get with the pregnancy, because progesterone is there, estrogen is there. So what is going to be the GI changes? So your GI motility is going to be decreased. GI motility, can anybody tell me what's the reason why GI motility decreases? Pregnant female always complain of constipation. They get constipation.
Because of progesterone again.
Very good, excellent, good job. Progesterone is going to slow down. Progesterone, what's the reason? Why the? Can anybody tell me the reason why has progesterone wants to decrease the motility?
To preserve it for the fetus?
Excellent, very good, good job. Because progesterone is very careful and it loves the baby. Progesterone thinks that if I increase the GI motility, it might lead to the uterine contraction and that might lead to abortion. So that's the reason GI motility is actually reduced. Progesterone is very careful, okay? So that's actually the reason. So you get what? Progesterone is going to slow down the gut. And similarly, progesterone will do what? It will also decrease the lower esophageal sphincter tone. Lower esophageal sphincter tone will be decreased. And when you decrease the lower esophageal sphincter tone, you will get reflux, GERD, gastroesophageal reflux disease will be seen. So this is the one reason of gastroesophageal reflux disease in the pregnancy. And second reason is a gravid uterus, which will compress the stomach. Get it? Now, what is the other effect of the progesterone? Progesterone, what's the effect of progesterone on the gallbladder motility?
Also decreases.
Increases stasis?
Everything in the gut, very good. Gallbladder motility will be decreased, very good. So that will increase the risk of what? Gallstone. Pregnancy increase the risk of gallstone, is it? Motility will be decreased. Get it? So pregnancy is going to decrease it. Get it? So this will be your, I would say, the GI changes which we are getting. Constipation, GERD, gallstones. Very, very important to know. Now, what endocrine changes are going to happen during pregnancy? Yep, they are very, very important to know. So that's the reason I'm spending more time here. Okay. So what will be the endocrine changes you are going to get during pregnancy? Yep.
Insulin resistance.
Very good. Why? What's the reason of insulin resistance? Most of the females get the diabetes during pregnancy. That is called the, pregnancy-induced diabetes. Yes, gestational diabetes, insulin resistance. What is the purpose? Why there's insulin resistance?
More glucose.
more glucose available for the fetal use, I mean.
Mother wants to leave the glucose available for the baby. So mother blood glucose will always be elevated for the baby, and that's the reason you get the insulin resistance. Okay, insulin resistance will be increased, and even insulin secretion is also increased because if there's no insulin effect, your insulin secretion will also be increased. So you get what, that's going to lead to lipolysis and fat utilization to generate the energy for the developing baby. So that's the purpose of your insulin resistance. Now, can anybody tell me what's the name of the hormone which is produced by the placenta that will lead to
Placental lactogen.
insulin? Very good. Placental lactogen. Very good. Placental lactogen hormone. Very good. Very good. Excellent. So that will be the insulin. Now, other changes which you will see during pregnancy it's going to lead to the enlargement of pituitary gland. So pituitary gland enlargement will be seen that will be due to the lactotrope hyperplasia. Lactotropes hyperplasia. Get it? So you get lactotrope hyperplasia of the lactotropes. Cells will be increased in the size. Get it? So lactotrope hyperplasia is going to be seen. Get it? Why lactotrope? Because prolactin secretion increases. What other changes you will see in the blood levels of the hormones? Yep. Anyone? What are the other changes you will see?
Estrogen, progesterone.
Yeah, estrogen is very high. So estrogen is going to increase the number of sex hormone binding globulins. Sex hormone binding globulins means the carrier proteins. It will increase the synthesis of carrier protein sex hormone binding globulins. It will increase the synthesis of TBGs, thyroid binding globulins. Correct? So thyroid binding globulins and it's going to increase the synthesis of your cortisol binding globulins. So this is the reason your total thyroid hormone concentration will increase during pregnancy, which I already discussed with you guys on the endocrine. Get it? All right. So coming to your skin changes, what skin changes you will see during pregnancy? Skin changes. Yep. Anyone? What skin changes you are going to see? That's important to know.
Gravidenum.
Yes, so you are going to get the stretch mark. You mean to say stretch mark because your skin will get stretched by the increased size of the uterus. Stretch marks. So you get the stretch marks. Yep. Stretch marks will be seen. Very good. So stretch marks. Very good. What else you are going to see? Because of the growth of the uterus, you will see the stretch marks in the area of uterine region. Where the uterus is growing, you will see the stretch marks in the female. Yep. What else you're going to do? What vascular change? Yes. So if your estrogen is very high, if your estrogen is very high, so you are going to get what? Very good. Estrogen is very high, you might lead to melasma, which is a mask of pregnancy. You get the brownish lesion around the nose area. So you get the melasma being there. Melasma. Get it? Melasma is there. Very good. Melasma is going to be seen. And this melasma also seen in the females who takes the OCPs, oral contraceptives. Okay. So melasma can be seen and other changes you are going to see because of increased estrogen will be what? You might get the spider angiomas. Why don't you say spider angiomas? Oh, we haven't discussed that in the GI. I will discuss that in the GI. So spider angiomas because increased estrogen will lead to increased proliferation of blood vessels. It will lead to vasodilation of blood vessels. So spider angiomas can be seen and the palmar erythemas are also seen. Palmar erythemas. Okay. Palmar erythemas, then varicose cities. Varicose cities will be seen. Varicose vein. What's the reason of varicose cities? Because of the stasis of the blood in the veins that's secondary to the gravid uterus. Okay. All right. So these changes you are going to see in the skin. Now coming to the respiratory system changes. What respiratory system changes we will see? Yep. There will be hyperventilation or hypoventilation.
Hyper.
Hyper.
Hyperventilation. Why? What's the reason? Hyperventilation because the mother is getting carbon dioxide from two sources, from her tissue and the baby's tissue. So there's a lot of the carbon dioxide being there. So increasing the carbon dioxide and that will stimulate the respiratory center. Respiratory center. Get it? So when you stimulate the respiratory center, you will get what? Hyperventilation. Okay. Hyperventilation is there. So if you get hyperventilation, what acid-base disorder you will get? Yep, that's very important to know. So pregnancy causes what? Respiratory acidosis,
Alkalis.
alkalosis, or
Alkalosis because we're losing carbon dioxide.
very good, very good. So you are losing carbon dioxide. So pregnancy will cause respiratory alkalosis. All right, it's going to cause respiratory alkalosis. Now, other system change is called renal system. Renal system. So we're going to discuss the renal system changes. So renal system, what will happen to the filtration fraction and the GFR during pregnancy? It will increase or decrease?
Increase.
Increases.
GFR should increase because mother has to throw down the waste products.
The waste.
The baby's waste product and her own waste products needs to be thrown into the urine. So GFR is going to increase, and how do they increase the GFR? They will lead to what? Vasodilation. Vasodilation. So you get what? Vasodilation. And that vasodilation is going to cause what? Increased renal plasma flow. And when you increase the renal plasma flow, there's a basic physiology we discussed in the kidney, you get increased GFR. Okay. So increased filtration is going to be seen. Okay. That's a one change. So if you get increased GFR, what will happen to the blood urea nitrogen level and the creatinine? BUN will be
Decrease.
decreased. Very good. BUN will be decreased. Creatinine will also be decreased because you are filtering out more. Okay. So what will be seen in the urine? Will you get glucose urea normally during the pregnancy or not?
Yes, normal. It's normal.
Why? Why? Very good. You're right. So you get glucose urea. You're right. Your answer is correct. Glucose urea. You get glucose urea. Yes. Yes. What's the reason of glucose urea? Because you are filtering out more glucose. So suppose you filter out 260 milligrams of glucose, grams of 250 milligram per deciliter of glucose, and you know the renal threshold, the maximum capacity of the PCT cell, proximal convoluted tubule cells, to reabsorb the glucose is 200. This is 200. It can only reabsorb 200. That's the maximum capacity, or I would say the Vmax of the sodium glucose co-transporter. You know, and that facilitated, what is the limitation of facilitated diffusion? It gets saturated. So that's the reason you will get 60 milligrams of glucose urea. So glucose urea, protein urea, that's normal during pregnancy, even at the normal plasma concentration. Okay. What other changes you are going to get during pregnancy? You might get the hydronephrosis and the hydroureter, even kidney stone formation. So you can get hydronephrosis and hydroureter, and that will be secondary to the gravid uterus. Gravid uterus will compress your ureter and the bladder. Okay, so you might get the hydronephrosis. So can anybody tell me hydronephrosis will increase the risk of what?
UTI.
UTIs. Excellent. So you might get the acute pyelonephritis with them. Acute pyelonephritis with them. Get it? So you might get acute pyelonephritis with them. Get it? So that these are the changes you are getting with the renal system. Now, last two systems are remaining on my ends. That will be your, I would say, the hematologic, hematologic changes, hematologic blood changes. So blood changes, what will you get? You will get anemia or polycythemia with the pregnancy. Hematologic.
Dilutional anemia.
Very good. Dilutional anemia. Excellent. Because plasma volume is increased, but your RBC mass is also increased. But as compared to the RBC mass, there's a more increase in the plasma volume. Volume is increased. Plasma volume is increased. So you get a lot of the plasma volume being there, and that plasma volume is going to lead to anemia. So you get anemia. So what other changes you will get in the hematologic system? You will get hypercoagulability or hypocoagulability.
Hyper.
Hyper.
Hypercoagulability. What's the reason? Yep. What's the purpose of hypercoagulability? Anyone? Because
Again, as a
Blood
protective
loss.
mechanism if the mother lose blood.
actually getting
prevent the birth.
ready. Mother is getting ready for the delivery because at the time of delivery she might lose the blood. So that's the reason she's getting hypercoagulability. Another, pregnancy increase the demand of the nutrients. So you might get the iron deficiency and the folic acid deficiency with the pregnancy. So last system changes is called MSK, musculoskeletal. So joints changes and the posture changes. You know, with the pregnancy, your joints get smoother. You get joint laxity or smoothness of the joint. Joint laxity or smoothness. Your joints will get smoother. Okay, so that will facilitate the descent of the baby easily. Okay, now other is actually you might get the posture changes which will lead to curvature of the spine. That's called the lordosis. You might get the lordosis. Lordosis because of the gravity uterus, female might get the lordosis to actually, realign with the center of the gravity. So these were the pregnancy changes being there. Now we're going to discuss the hormones of pregnancy. Then we have the lactation being there. Okay, so let's discuss the hormones of the pregnancy, beta HCG, all these steps. So we already discussed the beta HCG. I will just quickly go through the beta HCG with you guys. So beta HCG is actually produced by the syncytotrophoblast of the placenta. Okay. Now the role of beta HCG is what I already discussed. It's going to maintain the corpus luteum, maintain the corpus luteum, maintain the corpus luteum for how many weeks of the pregnancy? Maintain the
Sorry,
corpus
mister.
luteum for how many weeks of pregnancy? For
10
8 to
weeks.
yes, 10 weeks. So after 10 weeks, who's going to produce the progesterone? If corpus
Placenta.
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 placenta, very good. So it means your beta HCG level will also fall after 8 weeks or 10, is it? Beta HCG level. Will it fall?
Yes.
Mhm.
Yes.
Beta
It's
HCG
fall,
level.
but not.
Yes, it's going to fall. Beta HCG level is going to fall. Yes, you're right. It's going to fall after, okay. So beta HCG level is going to fall. Exactly. You're right. All right. So that's going to fall after 8 to 10 weeks of the pregnancy. Okay. And what's the other role of beta HCG? Yes. So this is the one role. Okay. And beta HCG level is used to detect the pregnancy, which I already discussed with you. Now you guys know that beta HCG have the beta subunits specific. It is a specific beta subunit, but alpha subunit is actually identical. Alpha subunit. Alpha subunit. Alpha subunit of beta HCG is actually similar to your alpha subunit of your TSH, thyroid stimulating hormone, your LH, FSH. They're the similar alpha subunit. So if they're the similar alpha subunit, it means if you're the high beta HCG, it's going to do what? It's going to cause hyperthyroidism. Hyperthyroidism. Get it? So, okay, hyperthyroidism can be there and increased LH-FSH activity can be seen with the high beta HCG. So remember, in order to diagnose the pregnancy, we always use beta subunits. Do not use alpha subunit because alpha subunit is identical to the TSH. Now, can anybody tell me what are the conditions or what are the diseases in which you get lot of the beta HCG, very high beta HCG?
Multiple
Molar.
gestations.
Multi
Molar pregnancy.
Very good. First, multifetal gestation means twin pregnancy. Very good. Molar pregnancy is there. Excellent. Molar pregnancy.
Choriocarcinoma.
Choriocarcinoma. Excellent. We will discuss all these diseases in the pathology. Very important. So, what are the conditions in which beta HCG decreases?
Miscarriage, abortion.
Okay. So, you mean to say miscarriage or abortions? Very good. What else? You mean to say
Ectopic pregnancy.
ectopic pregnancy? Excellent. What's the reason?
It's
Because
like a failing
yes,
pregnancy.
because in ectopic pregnancy, you do not get the formation of syncytotrophoblast. I mean to say normal syncytotrophoblast. So there's no proper formation of syncytotrophoblast, so no beta HCG. Very good. Ectopic pregnancy and other pregnancies like your okay. Yep. What are the trisomies? Trisomies, Edward syndrome and the Pettau syndrome. Edward 18, trisomy 18 and the trisomy 13, they will have the decreased beta HCG, and this is the reason these trisomies never result in the live birth. Never result in the live birth. because they will actually lead to the death in utero because they don't have a beta hCG. And the only trisomy which results in the live birth is called Down syndrome. That's the reason Down syndrome patients, Down syndrome. Okay. So that's actually Down syndrome for you. So Down syndrome is going to cause what? Increase in the beta hCG. Okay. Why in Down syndrome beta hCG is high? Because fetal functions are high during Down syndrome. And this is the reason Down syndrome leads to the live birth. Okay. All right. So that's all about beta hCG. And we already discussed another placental hormone which was called human placental lactogen. And human placental lactogen is also produced by your placenta. Human placental lactogen. And we already discussed this hormone. What was the role of this hormone, human placental lactogen?
Insulin resistance.
Insulin resistance during pregnancy. Okay, placental lactogen, and it's also produced by your
Placenta.
syncytotrophoblast. So it's going to supply the ample amount of glucose, proteins, lipids to the baby. Okay. Now Apgar score is very simple. I know you guys are very good in the Apgar scores. And let's discuss the process of lactation and the menopause. Okay. All right. So let's discuss the process of lactation. Lactation. So lactation is actually what, the lactation is actually start in the production of breast milk and the release of the breast milk. That's called lactation. So your lactation is going to start just after the delivery of the placenta and the baby. So once you deliver the placenta, it will lead to what? It's going to decrease estrogen, and decrease progesterone. Progesterone is going to be decreased, estrogen is going to be decreased. So once your progesterone, estrogen decreases, what will happen? That will actually stop the blockage.
Prolactin.
Yes, prolactin get independent. You get the independent, so prolactin will actually get independent. Prolactin will get the open hands. So prolactin start lactation, process of lactation, milk production. Okay, so this is the reason female start lactation just after the pregnancy. Now, what process is required to maintain the milk production and ejection? That is called suckling. The baby should suck. So suckling is actually responsible for the maintenance and the ejection of the milk production. Suckling. Okay. So suckling is actually required for the maintenance of the milk production and ejection. Get it? All right. So prolactin will actually do what? Induce and maintain lactations. Okay. Now, when the female is actually doing lactation, when the female is doing the lactation, the prolactin is high. So that will also inhibit your menstrual cycle. So this is the reason female during lactation, during breastfeeding, she does not have the menstrual periods. Menstrual periods being there. Now, breast milks. So, what are the benefits of breast milk? Breastfeeding. Yep, anyone? Breastfeeding. Benefits of
Has
breastfeeding.
immunoglobulins.
Yep, it's going to give
Has
immunoglobulin. Very good. What immunoglobulin? Immunoglobulin A, G,
IgA.
IgA. Very good. So give immunity to the baby. IgA immunoglobulin. Very good. Immunity to the baby. Very good. Yep. And it can also give macrophages, lymphocytes to the baby. Immunity. Very good. That will decrease the risk of infections in the baby. Infection risk is decrease. Okay. Infection risk is actually decreased in the baby. Yep. All right. And this immunity mother breastfeeding will do what? Breastfeeding is also going to reduce the risk of other diseases like asthma, allergies, even diabetes, and the obesities in the. Can anybody tell me why? How it decrease the risk of diabetes, mellitus, and the obesities? Mm-hmm. Yep. Because the baby will not consume the high calories intake, is it? So he's going to consume the less calorie intake. That's called breastfeeding. Now breastfeeding is recommended for exclusive breastfeeding should be there for the babies less than a 6 month. Okay. Now, other benefits of breastfeeding is what? Breastfeeding will decrease the risk of ovarian cancer and your uterine cancers in the mother, even breast cancer. Can anybody tell me why? How breastfeeding decrease the risk of ovarian, uterine, and the breast cancer in the mothers?
The estrogen reduction.
Excellent, very good. So when female is actually breastfeeding, when female is breastfeeding, okay, when female is breastfeeding, she has a decreased GnRH because prolactin is around. So you get what? Decrease estrogen. So decrease estrogen means decrease number of ovarian cycle. When you decrease the number of ovarian cycle, it will decrease the risk of the cancer. Get it? So similarly, you will also have the decreased risk of endometrial cancer and the breast cancer as well. Okay. All right. So hopefully menopause is remaining and some tenor stages are very easy. I think you guys can go through them and not a much important. If I will briefly go through that, and tomorrow hopefully I will start the pathology with you guys. Anybody have any question? Any confusions? Yep, I think you guys have the UL class at 2 p.m. Is it? Do you have a UL class?
Yes. Mhm.
Okay, so anybody have any question, any confusions? Okay. I'm sorry for the yesterday and sorry for the delay today. Hopefully tomorrow we start at our proper time. Okay. Thank you for coming and have a good day. Bye bye. Take care.